Hello everyone and welcome to AceOSCE's video for today. Thanks for joining me, Alicia. And today I'm going to be going over an important topic. A lot of us, when we're looking at questions from antipsychotics, antidepressants, we get a little confused in side effects and classification. What are the options? How long drug trials go on for? So in this video, I'm going to try to address all those questions for you. We're going to look at the classification of antipsychotics, a little comparison chart between first generation and second generation antipsychotics, so that if you guys ever get questions in your PEBC evaluating exam or even the MCQ about which sort of antipsychotic should be chosen for a specific patient for their specific conditions, it would be really easy for you to find and identify those points that are going to give you a little bit of a hint as to which is the best agent for them. So let's go ahead, let's get started with the video, and welcome to a quick review with AceOSCE for the classification and comparison of antipsychotic medications. Again, we'll quickly have a look. This is a review. There are minute differences between each medication, as most of you would know, in terms of pharmacokinetics, pharmacodynamics, in terms of patient selection. That is, this is a quick review, so I probably won't go into that for now. So this is a broad overview of antipsychotic drugs. As most of you know, there's first generation, which are FGAs, or second generation antipsychotics, which are SGAs. Antipsychotic drugs are denoted by AP in this video, and first generation are further divided into low potency and high potency first generation antipsychotics. The low potency ones are like chlorpromazine, thyroidazine. The increased potency ones are more like fluphenazine, haloperidol, loxapine, pimozide, trifluoperazine, or chlorpropazine. In terms of the second generation antipsychotics, we have those that we usually see more dispensed in our pharmacy because they usually have lesser side effects and lesser monitoring requirements. For example, aripiprazole or Abilify, the clozapine, the racidone, olanzapine, quetiapine, risperidone, ziprasidone, and paliperidone. Again, I want to remind you guys that even though this is a broad classification, you may get the same options, like, for second generation antipsychotics is 4 different options in your question, which means that each medication is different in its pharmacokinetic properties. You may want to select one second generation antipsychotic over the other because of different properties of that medication of causing, say, weight gain or a specific side effect that is beyond the scope of this video at the moment. But each and every one medication is really important for you guys to know about. So make sure that when you're reading this topic, you also read about each medication separately and have a little bit of an idea about the drug interactions of each medication and what is special about each medication in terms of side effects or selection properties. Here's a quick comparison of FGAs and SGAs. In terms of the field, or what we're comparing on the left, FGAs in the middle and SGAs on the right. So FGAs are also called typical antipsychotics and SGAs are atypical antipsychotics. A lot of times PEBC may not write first generation or second generation. They would expect you to know what typical and atypical antipsychotics are, so this is what they are. In terms of metabolic side effects, first generation antipsychotics have lesser metabolic side effects in comparison to SGAs. So you'll have more BGLs or more weight gain in SGAs than FGAs. The mechanism of action of FGAs or first generation ones is usually just D2 receptor blocking activity. Again, that is usually, some of them may have additional properties, but this is the main case. Whereas in SGAs, you have D2 as well as 5-HT2A receptor blocking activity. So there's additional activity for SGAs as well. In terms of EPSEs or extrapyramidal side effects, which are a big concern as side effects with these medications, they're more likely in FGAs, which is why SGAs or second generations are usually more preferred as treatment options over first generation antipsychotics. This is the reason. And EPSEs are higher in FGAs, so more likely to cause dystonia, akathisia, TD, which is tardive dyskinesia, or Parkinsonism. All of these terms PEBC would expect you to know. They would expect you to understand what these mean, so that if they describe the symptoms, you would know how to match it. The EPSEs, however, occur less in SGAs. Let's have a quick look at the algorithm. So now this is the treatment of a psychotic episode in a patient, and this is something that I copy pasted from the the CTC. So this is a really important chart for almost everything. Again, this is important for your MCQs. Everybody who's giving their evaluating exam will definitely be giving the MCQs. So this is just to summarize as to how long a trial for antipsychotic goes, what we select and what we don't. In case it's not easy for you to look at this video right now, or it's a little hazy, maybe take a screenshot of this and enlarge it whenever you get the chance. Or if you have access to the CTC, definitely go back and look at it, because it does give you really important pointers. So on the top box, it does say second or first generation antipsychotics. You have to, of course, give them an antipsychotic if they're having a psychotic episode. However, usually in most cases, SGAs or second generation antipsychotics are the way to go. Just because, like I said, EPSCs are a big concern as side effects of FGAs, which is why second generation ones are usually taken into consideration. Once you start them, a 4 to 8 week trial is what you need to do. So it's not something like you do 1 or 2 days or 2 or 3 weeks. Usually for antidepressants is 2 to 4 weeks. This is 4 to 8 weeks. So this is an important timeline. PEBC may ask you for this, so keep this in mind. Going further, if there is effectiveness or it is tolerated, on the right side you can see you just continue the antipsychotic medication at the lowest effective therapeutic dose. Continue to monitor the response on whichever scale is helpful, and the side effects, of course. Regardless of which antipsychotic you choose, you want to make sure the patient is not having too many side effects. Expect gradual improvement in negative symptoms and functioning over 6 to 12 months or longer. So again, a question can come: how long does it usually take for antipsychotic medications to show their effect on negative symptoms on a psychotic episode? So that is usually 6 to 12 months or longer. Use appropriate physiochemical interventions. Educate the patient and the family about early warning signs of relapse. So in case you stop the medication, what happens, what to expect, and when to come back to the doctor for probably reassessment, as well as maybe represcribing the medication in case they're relapsing. And again, you can taper with antidepressant if the symptoms of major depression are present. So you can treat it with the antidepressants as well. Therefore, you'll see in your clinical practice there's a lot of times where antidepressants are given with antipsychotics. In case that is effective, that is perfectly fine. You just continue the antipsychotic medication for 1 to 2 years for the first episode for a full recovery of patients with symptoms and functions that are recovered. You want to do at least 2 to 5 years in the first episode if the patient has any long drug interactions or some problems with their mental health, that is previous mental health problems. At least 5 years following 2 or more episodes, and again monitoring with the doctor, of course. In case there is a relapse, we go back to square one. On the left hand side, you see if there is no effect even after a 4 to 8 week trial, you want to start SGAs if not on current therapy. So for example, if you have started the patient on FGAs at its first generation, there's no effect, you either switch it to an SGA or you start an SGA if it is not already there. We wait for another 4 to 8 weeks. In case it's effective, we know what to do. In case it is still not effective, if there is a limited response or reassessment, you may have another few options. You may have treatment resistance, so you may have to go in for something called clozapine, which all of us know needs WBC monitoring every few weeks or months, depending on how long the patient has been stable on it. In case schizoaffective disorder or bipolar disorder is diagnosed, we need to have adding mood stabilizers such as carbamazepine, lamotrigine, lithium valproic acid, depending upon what is diagnosed. And again, a 4 to 6 month trial is needed. So hopefully that kind of helped you guys out to understand the timelines of how long we use FGAs and SGAs for. I know it may be a little confusing for everybody who hasn't gone into so much depth, but I did want to bring this to your attention because these timelines are important. So the question for today is, after being on olanzapine for about 2 weeks, your patient exhibits rash, fever, swollen lymph nodes and face. What would be the best option to help this patient right now? A would be to stop olanzapine and manage the side effects, or reduce the dose of olanzapine, or replace olanzapine, or it's probably an allergic reaction. Let me know what you think, the answer in the comment section below, guys. And if you have any other topics you want me to make videos on, let me know. I try to make videos on topics I think that you guys are finding hard after I see people performing their mock tests. And again, we have the mock tests running live right now. There are a few slots available right now. Maybe some of you are not able to find slots with me at the moment, but I can try to open up extra slots in case more and more people want to fill in one spot. So definitely DM me in case you're interested, and I will see you in the next video.